Thank you so much, sir. With great honor and respect, I would like to request Dr. Shinto, Adit S. Shinto, our nuclear oncologist, to gift him with a memento in honoring him for presenting such a beautiful seminar presentation on Dr. C P Mathew sir's memorial seminar. Thank you, sir. Dr. C P Mathew sir was no more. Something said in my mind when we were thinking, what next? What is to be done? So God was giving us a doctor from one stage to another stage. When Sir was not, when Sir passed away, we didn't have a doctor at that time. We had our beloved Dr. Marcos to help us. After that, Dr. Shinto joined us. Time always saves us, because if we are for the good purpose, Dr. C P Mathew sir used to say, if we are good for the good purpose, God will bless us. So no need to worry at all. So proudly and humbly, definitely I invite Dr. Ajit Shinto for his next session. He is a very efficient nuclear oncologist who has more than 20 years of experience in the field of nuclear oncology, and he is so humble because, as you all know, that I am not a medical person. I am a PRO of Charian Ashram. He talks to all of us very respectfully, and he, in spite of his vast knowledge in modern medicine, he accepts all other systems of medicine, and he asks us, could you look after this? And he talks to Dr. Anu and Dr. Ramachandran. So we are blessed with the team. Over to Dr. Shinto for his session.
Thank you. It's a very generous introduction. Thank you so much for taking time out on a Sunday and joining us from various phases of life as well as students. I believe you all have hung posters down which you have to go and graduate in sometimes. So all the best to all of you as well. So without much ado, I embarked on this talk which is a little bit more philosophical because I think for me the whole process of joining Charian Ashram as well as practicing oncology here is completely different to what I have been exposed to, trained with over the past 20-25 years when I was in mainstream oncological practice. So for me it was a very big learning experience because I was exposed to integrated therapy for the first time when they were requesting me to step into the huge giant shoes of Dr. C P Mathew to take forward oncology care. I thought I could do only what I have been trained to do and what I have been practicing for the past 20 years. And over so many months I have been trying to learn the system which was adopted by Dr. C P Mathew, which found so much success and so many smiling patients. You know, for a cancer doctor, it is very rare to see patients who come in smiling. And that's a sad truth of our speciality. We do not see happy patients. And Charian Ashram was definitely a different kettle of fish for me because I used to see my patients actually happy. And that used to always make me very emotional because I knew fundamentally we as cancer people treating allopathic doctors were doing something wrong. You know? So that's why this talk is going to be a little bit more philosophical. It's going to deal to a certain extent about the evolution of oncology. That's why I termed it as the length, breadth and depth of oncology. Your new cells getting produced and old cells getting died, and different blood cells or different cells have different lifespans. Like, for example, I'm sure most of you know that red blood cells have a lifespan of 120 days. The same bone marrow produces lymphocytes which have a lifespan sometimes of 10 days, and sometimes you have natural killer cells which are much lesser. So all these produced by the same organ but in different functional modalities, having different cell cycles as well. And everything has got a programmed death. So cancer, unfortunately, is a disease wherein the cell's mechanism of auto-death does not work, or contact inhibition as we know it, you know, because normally when cells come into contact with each other, they actually are forced to die. You know, because it's in the same confined space. So the concept of contact inhibition is not there, and cancer results in unwanted growth. You have a growth which is there, for example, in the breast or in the brain or in the lung or in the kidney, or wherever you have an unwanted growth. That is essentially what is cancer. And how does it occur is a question that we've been struggling to answer. right from scientists at the bench level to clinicians to various people across molecular biology, genetic biology, tumor biology, etc. We've all been struggling to answer why does cancer occur, and it is a complex interaction of multiple parameters that come between the body, between the environment, between tumorogenic stimuli, which can be external, internal, smoking, alcohol, pollution, food, poisons, plastics, a whole lot of things. So it's a very complex interaction. We cannot put our finger on as to, when you're asking God, why did I get this cancer? It's very, very difficult to answer that from a human perspective. I'm sure God has a better answer. In fact, there is a huge publication which made headlines in the Lancet, which says, ultimately you get cancer because it is written in your stars. You know, that after all the scientific evaluation, ultimately അവർ പറഞ്ഞു വരുന്നത് തലവരെയാണ് ക്യാൻസർ കിട്ടുന്നത്. അല്ലാതെ നമുക്ക് ഇതുകൊണ്ട് ക്യാൻസർ വന്നു, അതുകൊണ്ട് ക്യാൻസർ വന്നില്ല എന്ന് പറയാൻ പറ്റില്ല. Then, what is it? The next one, does it behave the same in all people? Obviously no, because we have realized over time that all cancers cannot be treated the same way. All people with the same cancer cannot be treated the same way. All people with the same cancer in the same stage do not behave the same way, do not respond the same way, do not live the same way. So we still do not have answers to a lot of questions as to why some patients do well. Like Sir very rightly put it, we don't know which God is taking care of these patients. So we have really no idea what we are doing with majority of the time. Why certain cancers spread to certain organs? There is a theory which is called the seed and the soil theory, which means certain seeds survive only in certain soil. So if you have a breast cancer, very often you would see that they spread to within the breast, to the lungs, to the bone, to the brain, and sometimes to the regional lymph nodes. And why doesn't it spread more into the spleen, or why doesn't it go to the pancreas? Is because these other organs are more favorable for for a breast cancer to spread, and that is why it's called the seed and the soil theory, and that's a very basic explanation. Why certain cancers tend to, for example, if you have a thyroid cancer, it tends to go to the regional lymph nodes first, and certain lymph nodes more than the others. For example, it doesn't go to the submandibular lymph nodes or submental lymph nodes because the lymphatic drainage for the thyroid is a cervical, especially the upper, middle, and lower cervical group. So it's basically through lymphatic drainage or through blood that cancer actually spreads. And blood goes into every organ, but certain organs act as a perfect soil for this breast metastasis to be seeded into it. And why we have specific symptoms? Obviously because it is of the area that the cancer is. Obviously a breast patient very rarely present with leg pain. They will present with breast heaviness and breast pain, brain tumor similarly. I mean, each organ, depending on where it is spread as well as where it is presented, the symptoms are going to vary. And for the basic layman, it would be nice to know about the 4 stages of cancer at least, where stage 1 is, according to me, is a pure surgical disease. That means you can definitely operate it and take it out, and you can rest assured that almost 70 to 80% of the time you would be able to cure the patient. That is why it is important to diagnose cancer early. See, the one thing you should remember is every one of us have cells which can turn into cancer, and there are already some cells which are mutated within our body. Our body's immune system is the only thing that prevents those cells from actually becoming a full-blown cancer. So right from childhood, children as well as older age group, right up to 80s or 90s, have cells within your body. Cancer the only question is our body capable of overcoming that small limitation, or are we going to succumb to it? And that is where the host as well as the tumor interaction becomes very important, and our body's immunity plays a significant role, which is often overlooked in general oncological practice. Yeah, as I was saying, the stages of cancer, stage 1 is the early stage, or the very early stage, where it is purely a surgical disease according to me, and my concepts are still evolving. I'm still a student of oncology. But from what I understand, stage 1 should be operated. Stage 2 means very limited spread to just the nearby area, which again most likely you would be able to operate, or if you want you could give some sort of therapy to shrink the tumor a bit and then operate, and followed by some other forms of adjuvant or therapy as well. So the ones which come before surgery could be called a neoadjuvant, and the ones which come along with surgery or afterwards, which the disease has spread to multiple parts of the body and it is rarely operable. Hardly ever radiation therapy is possible except for palliative intent, and most likely you are stuck with palliative intent chemotherapy or pure palliative treatment. So those are the 4 stages of cancer. And that is where, as an oncologist, in your future, when you students also start practicing oncology, which I hope many of you will start doing, it is important to generally in your mind focus on whether this patient who's in front of you belongs to the curative ambit or is it the palliative ambit. So you would like to know, is this patient curative? Then do whatever is the best possible available treatment right then and there to cure the patient, because with then you can close the chapter and put the patient on maintenance for the rest of their life. The patient comes in for palliative intent, then it becomes more a question of how do we treat this patient in the best possible manner without damaging the patient any further, at the same time improving his quality of life, as well as symptomatology, as well as his performance, enthusiasm, mental anxiety, everything comes into play in a palliative intent. While with curative intent treatment, we know that the patient is going to undergo some kind of difficulty, whether it is curative intent radiation therapy, curative intent chemotherapy, or curative intent surgery. It is going to be tough on the patient, but it's probably worth it because you can, technically speaking, cure the patient. So now LBD is the length, breadth and depth of oncology. So what is the meaning of this topic actually? So after the basic introduction of oncology or cancer, what I mean to say is, this is the more philosophical talk as I mentioned. The length in oncology definitely, it refers to the amount of time the patient has experienced a particular problem. So that's the length, etra samaya. The breadth is the type of problems the patient is facing with regards to the cancer. That is the symptoms. What is the patient presenting with? So most of the time as oncologists, when we hear a presentation, we ask, okay, how long have you been having it? Okay, what are your problems right now? And what is your diagnosis? These are the 3 things which anybody says. So when we are presenting our case also, patient is a 48-year-old female, is known case of CA breast, invasive ductal carcinoma by biopsy, initially presented with lump in the breast for the past 4 years, and then slowly underwent so and so, so and so, so and so. This is your history. This is what you say the length and breadth of thing. One thing as oncologists we have always been struggling is the depth of oncology. And that is something we have no clue about. Because we don't exactly know what is happening in the inside of the patient. How is the body reacting to that particular tumor? What are the factors which are contributing to its growth? What are the factors which the body is contributing to fight this? What exactly tumor markers are expressed? Which metabolic pathways are coming in? Which new proteins are being secreted? Which immunoglobulins are used by the body to fight it? How is the body's other systems coping with this? All this we have no clue. Because that is the actual crux of the matter. That is what we need to treat to make this patient better. By looking at whether it's 3 years or 5 years doesn't give me enough idea. Maybe some idea, but it doesn't give me enough idea on how to treat the patient. By the symptoms, I have a better idea, okay, these organs might be affected, this is what I need to focus on. But actually, how to treat that particular problem, you have to delve into the depth. And the depth is something which all of us are clueless about, because we still don't know. Each patient is different, each body is different, each cancer is different. Even the cancer which is there in a patient's body now will not be the same 2 years down the line. Cancer would itself have changed so many times. Many of the times you see a primary lesion in the breast, if it is spread to the liver, it behaves in a totally different way compared to the breast lesion. If you do a PET scan, you will see this one's activity level is 2 or 4 or 6, the liver's activity level is maybe 3, and the bone's activity level is 12. How do you explain such different subpopulation of cancer cells within the patient's body? That means we have no clue. We are relying on a single biopsy from a single area. മറ്റൊരു 4-5 സ്ഥലമാണ്. The other 4 or 5 areas, how is the same cancer which is spread there behaving? What has that soil done to this seed? We have no idea. So that is where the depth of oncology is a very important factor when you actually think of treating the patient. Now if you look at the history of proper documented oncological care in allopathy, you would realize that there is a nice historical treatise which is written by one Indian author. It's called The Emperor of All Maladies. It's about cancer and the amount of research that has gone into cancer. It's a very beautifully written book. Interesting read, but it's very big. About how chemotherapy, radiation therapy, screening tests, mammogram, a whole lot of things he covers. It's very good. So that is something, but you should remember that our proper documented allopathic system of medicine for oncology is less than 200 years old. I mean, that's all the knowledge we have. And it was all trial and error method of some chemotherapeutic agent, some poisons we were keeping on injecting, and that's how our whole thing started. And you should remember that essentially the treatment of cancer is like assume, okay, now just assume that you have a forest and the forest is your body and you have some unwanted trees or plants in the forest and that is cancer and it is growing at such a rate that the normal animals as well as the normal trees and the plants in the forest are getting affected. So if the length is the number of years it's been growing in the forest, the breadth is how much area it is covering, and the depth is what is that particular tumor plant doing to the rest of the forest. What is it doing to the water supply? What is it doing to the air supply? What is it doing to the sunlight? What is it doing to the rest of the plants? This is your depth of oncology. So in this forest, how allopathic medicine chooses to kill that particular creeper, which is cancer, is by 3 main modalities. One is the most crude. You take a knife and chop everything that you see off in the hope that cancer things also will be eliminated. The problem is, if you are a good chopper, you will go to the root and chop it off. Otherwise, you chop the top and the thing will grow back as a recurrence. The second thing is you use fire. So you burn an entire area of the forest saying that this area is cancer, we will burn the entire area, that is radiation. So what happens along with cancer, tumor cells, the surrounding area also gets fried. So if you have a lung lesion here, surrounding lung area will also get fried. That is your fire. And the third thing is, now let us attack the water supply. We will put poison into the water supply of the forest so that anything that is growing there will die. And that is your chemotherapy. You inject it into the vein, it circulates in your entire body, it will go to every part, it will damage the cancer along with it. Some other parts also will get damaged. That is where all your side effects come. All your nausea, vomiting, loss of counts, loss of taste, mucositis, skin, nail, hair, anything that is actively growing in your body, it shuts off. So your blood cells are getting repetitively renewed, shuts off. Mucosa renewed, shuts off. Nail renewed, shuts off. Hair shuts off. Almost everything. This is not because of chemotherapy, naturally. But essentially this is what it does. So the important thing is, our allopathic treatment is only 200-300 years old. Surgery is older, but technically speaking, let us put it as properly documented research for cancer. 200-300 years old, vis-a-vis a disease which has been growing for millions of years. It has millions of years of hindsight to look back into, to grow, to mutate, to come to the next level and evolve over time. Millions of years cancer has evolved. How much have we learned? 200 years. We are in no competition with cancer. Cancer is going to beat us every day of our lives because we are millions of years behind cancer. And that is something we have to accept as oncologists because we are never going to beat it in its entirety. So there is a famous theorem called the Hunter theorem, which is not so famous, but I like this theorem. It is basically that different cancers grow in different places. It's like a hunter. So all oncologists are hunters. We are going hunting after cancer. Cancer big boss is somewhere there. Now you have to know which cancer it is, where it is going to hide. So that is the first thing a hunter has to do. Now, if he has to shoot a duck, he has to go to the water. He cannot go to the mountain in Himalayas and shoot ducks. So obviously you need to know where you're going to hunt and which place it's going to grow. Then you have to understand that there are different environments to hunt. So you have to be prepared when you go into that environment. Hunting in the brain is not the same as hunting in the lung, is not the same as hunting in the liver. So the hunter has to be prepared. Next, each has a special characteristic to attack. So each animal you want to hunt attacks differently. If you are going to attack a vulture or an eagle, you have to be prepared that it's going to sit and claw out your eyes. But if you want to be hunting the elephant, you have to make sure that you stand a little far away and don't shoot his bum or something. Don't shoot from front of him. If you are shooting a lion, you need to make sure that you don't make any noise. So the animal that you choose to hunt, suppose it is an alligator, suppose it is a crocodile, you will hunt in a different manner. If you want to catch fish, you will not use the same technique as to catch a chicken wing. So it's the same concept. Know your cancer, know your body type, know your environment when you're going hunting for cancer. Remember that some cancers can hide only in certain specific places. They cannot hide everywhere. So you have to make sure that you look at those places as well. Each has a specific pace of growth. It's like the tortoise and the hare story. If you want to catch a tortoise, you don't need to run so fast. You can go slowly after the tortoise and catch. If you have to catch a hare, you have to hop like him, you have to make sure that you go faster. If you want to catch a panther, you better make sure you don't run anywhere, you sit on top of a tree and you shoot. So you have to be sure as to which animal you're carrying, because each, not only the place, the pace of growth also differs. Some are more intelligent, some are faster, some are stronger, and some don't die with the knife, poison or fire. You have to accept this. So you have to make sure that you come up with newer techniques to fight this cancer. So from what I'm intending to say is that allopathic tools are very primitive tools. We are like the Stone Age of cancer right now. We are still there, club, fire, poison, these ways of, there is no drone attack and all as yet. We are coming to drone, which is more targeted therapy and all in a later phase, but right now we are almost all cancer centers focus on these caveman tools. But cancer or any disease for that matter, as a physician, before I became an oncologist, I was a doctor. So as a physician, you should remember that cancer has had the best motivation to learn, to grow, to adapt, because they have to survive. We never had to do. Physicians and doctors never had to learn about cancer to survive. You understand? We can survive in spite of cancer. So we are doing it as a time pass. We are doing it because we are specialists in that area, or we consider ourselves specialized in that area. And I have a problem with specialization also. My problem with specialization is that the more specialized you become, the lesser you know about anything else. You do not respect anybody else because you think you are on top of the mountain. While you realize that on top of the mountain you are alone. What will you do when you start standing on a mountain alone? You need to be down where with other people, then only you can fight and do things together. Before there was MBBS doctors who used to do deliveries, they will do operations. Then from MBBS they became MS. They will do only operations. They will not know diabetes control. They will call physician for diabetes control. They will not know blood pressure. They will call cardiologist for blood pressure. They will look at an ECG like it is something out of this world. Oh, please examine and tell me if the patient is all right. Surgeon. From surgeon, then you become onco-surgeon. Cancer surgeon. I will treat only cancer. If there is a fissure in ano or piles, I will not look because it is below my dignity. I just studied it and came. In MS, you are sitting and cleaning assholes only almost all your time. But still, when you become onco-surgeon, you will refuse to look because it is an asshole and it does not have tumor. So then what happens? You become only cancer-oriented. From MCH, then you become gynae oncologist. Then you will look only at breast and ovary, nothing else. So among cancer surgeons, then you become even more specialized. Only breast, only gynae. Then you become a breast onco-surgeon. Then you look at only breast. From there, you graduate to the next one who does only BCS, which is breast conservation. Breast conservation means before mastectomy was the rule, It was in relatively easy surgery, more morbid, but it was relatively easy. Breast conservation means you have to conserve. Then comes the next level, oncoplastic breast surgery. Means what? You will reconstruct the breast also, along with taking out the tumor. And see, the futility of so many years of training is the fact that what you knew 10 years ago, you can't practice. You can only practice breast, which has to be conserved. There is it. And I don't understand, after so much years of training, all this knowledge is going to go waste. I mean, that is again a philosophical thought for me. But anyway, so as I mentioned, we all have cancer cells, and it is only how our body reacts. So there is a famous quote which some great man has said, that doctors often, which will, by incidents, I have 2 more quotes of Hippocrates, by the way, because that's the oath that we take. Of course, right now, Modi ji's government has managed to shift that around to a lot of Indianized version of the Hippocratic oath, so we don't have to really rely on Apollonia and Vinicius and some other gods which the Greeks used to follow. Anyway, so the famous quote, in case people are not aware of it, is that doctors often treat the human body, of which we hardly know anything, or very little. For diseases, we know even less, because we don't know what the shit this disease is doing inside. And with medicines that we know even lesser about, because they've just got come few years ago. So what do we know about them? Somebody has manufactured them. So we don't know anything about the patient, we don't know anything about the disease, much less we know anything about the medicines that we use. Then what are we? We are very glorified quacks. That is all that we are. So this is where I think I was introduced to the concept of integrated therapy. And for me, it is a big eye-opener, because I was never exposed to any Ayurveda, Siddha, homeopathy, yoga style of treatment. I was born and brought up in the Gulf, typical Gulfi child, unexposed to any of the vagaries of Indian literature, science, culture, nothing. Came here, was totally screwed by the entire system around, because I was born and brought up outside. And so I came inside here and I had a lot of relearning of my values, relearning of myself, relearning of how to relate to people, etc. Because if you see, people who are educated and born and brought up in first world countries, or so-called first world countries, they don't know how to interact with Indians. Once they come down to India, for them privacy is everything. You cannot go and touch them. You cannot, lack of respect. How can you call me like this? What is happening? You want to talk? Can't we just text? It's like, I can't relate to my nephews or nieces who are outside, because I don't know what to tell them. I say, how is college? Yeah, cool. Okay, any friends? Nah, not really. Like, how do you have a conversation with children like this? So, what I'm saying is, I was not so bad, a little bit more mediocre Gulf for first world, second world of number. But when I came in, I had a tough time. Why did I start telling you about this? I was exposed to integrated therapy in oncology. So I had a whole lot of relearning, like I relearned myself when I came to college to do in St. John's MBA base in Bangalore. I had to relearn myself as an oncologist when I came here, because there are a lot of set of challenges which I was totally clueless about, which people seem to be handling with ease here. For example, chemotherapy complications, patients with unhealing fistulas, patients with mucositis, patients who could not tolerate chemotherapy, patients who had abdominal distension, nausea, vomiting, loss of appetite, loss of quality of life, bedridden patients, morphine tablets, any number of things. And we seem to be doing a fairly good job without an oncologist on board. I mean, after C P Mathew-3 was there was nobody handling it. I could still see happy patients around, and it was a big thing for me. And I took up a huge responsibility, saying, I will try and do something. And I was unsure. I had to learn all these protocols and regimens, because none of them are used anywhere in any other cancer center for the past 10-15 years. They are all very primitive allopathic treatment protocols. Then, after some extended reading, I realized that even the biggest cancer centers in the world, MSKCC, Mayo Clinic, MD Anderson, actually offers the patient a chance at integrated therapy. They give you an option if you want to undergo integrated therapy. They give you an option for Ayurvedic treatment. Can you believe it? They give you an option if you're a Chinese to do Chinese traditional medicine along with your allopathy. they are broad-minded enough to accept, but we who do not accept our own systems of medicine, which is a big failure because I was not educated. I did not know, I was not exposed. It is my fault, I should have sought it out, but I was not exposed. There was no avenues of exposure till I came here. So I also started learning in a very small, passive way, not a very aggressive way, as to what are the strengths of this particular system of integration that we could follow here. And over some time, what I realized that is Dr. C P Mathew-'s absolute doyen here. Like, hats off. I mean, at that age, in that stature, to be humble enough to go and learn another system of medicine because it is going to benefit my patient, or it has the potential to benefit my patient, is the ultimate thought of anybody. And that is where, somewhere, as my last point, I say that we all should start thinking of ourselves as healers and not as doctors. Because as doctors, if you go, you will always fail. You will you will be facing so many failures, it is unbelievable. But if you work as a healer, you will never fail because you treat both the patient as well as the disease and the community. And there you will heal and definitely you will find success. And so that is where I feel thousands of patients with this unique concept of comprehensive oncology care have significantly benefited, and have stood testimonials, as you could see in the video before, and they're still living testimonials who come to me after so many years, who are still happy. In fact, some of them are so happy, they ask me whether I'm C P Mathew-'s son, you know. I was beginning to wonder whether I look very similar to him or what it is. Maybe it is just a smile, I don't know. Ultimately, it's a big compliment for me when they ask me something like that. And allopathy, his system was always used in very minimal amount whenever necessary. Majority of his mainstay maintenance therapies were Ayurveda and Siddha oriented. And unfortunately, I never got to actually see or listen to him. But I have only been reading the files and trying to learn retrospectively as an analytic mode what I could do. And as Sir had often said, I mean, I did not listen to this, but I still made it as a concept out of what I have learned from him, is that his aim of treatment was always health. And health is a feeling of mental, physical, social and sexual well-being. That is the ultimate definition of health. If a patient feels he is mentally healthy, physically healthy, sexually healthy and socially healthy, that patient is healthy irrespective of the diagnosis. You might have the gravest of diagnoses hanging over your head, but if you feel that this patient feels he is healthy unless something else is really going wrong, or the patient is a little off track and he's on morphine or something like that. Yeah, totally cool, doc. Then it's a different matter. But otherwise, mainstream cancer care always leaves the patient sicker than they are before. This is something that I've honestly seen. Majority of the time, patient comes with a small lump, you do a mastectomy, patient is sicker than before. Patient comes with a small tumor, you remove that, very often they are sicker than before. Very often after radiation, patient is worse than before. Very often after chemotherapy, patient is worse than before. And that is why I always say allopathic modality is a destructive modality. We know only how to destroy, not other fields of medicine, any disease. That is the only thing that we know. We know only destruction. Infection, cut, take it out. Everything is destruction. We don't have any constructive phenomena at all. And that is when I thought there was a totally different mindset from the Ayurveda Siddha community, that I felt that they are always into construction, hardly ever into destruction. So that is where I feel integrative onco treatment has a perfect blend, because you can use destruction whenever you want to, and you can use construction whenever you want to, and you can bring them both together to have a nice balance, so that the side effects of one could be overcome with the other in a fairly rational-minded, blinded sort of way. So that is what I learned. And even if patient is fourth stage, who cannot, will not, or cannot afford to a further therapy, be it surgery, chemotherapy or radiation therapy, we were still using it left, right and center, benefiting our patients. Patients who had undergone multiple, you won't believe it, between the second talk and first talk, I had 4 patients waiting downstairs whom I had to go and see. One of them has undergone 4 different lines of chemotherapy along with some bone marrow transplant, this, that, farana, a lot of things. And that patient is still coming to us for integrated oncology treatment. Can you believe it? The patient is doing reasonably well? And they're on follow-up with RCC also. RCC is also surprised, scratching their head, what is the patient doing different? Because this patient stopped taking medicine from RCC long time ago. So this is the situation we are in. Even at this fourth stage, sir, you should treat these patients. That gave me some confidence. So if sir could treat them, let us also try the same thing. That is all. I haven't learned about this, but over the year, I mean, it's been just around a year. November 15 becomes a year that I properly joined Charian Ashram. Before that I joined and took a brief break. But I really feel that over the past 1 year, I have grown as a person who could treat patients better. Not as an oncologist, but who could just treat patients better by knowing where I could use something that I had learned vis-a-vis using something that I'm beginning to learn from other modalities. So significant benefits in symptoms, immunity, quality of life, pain relief, feeling of wellness is something that I've observed consistently on a daily basis because I do my OPs here every day. And I think this is the last 1 or 2 slides. This is another from Hippocrates or attributed to Hippocrates, but it's Latin, so I can't understand why the Greek chap wrote in Latin. But anyway, primum non nocere is something that we as physicians should always remember as a guiding principle because it's one of the few things in allopathic medicine which makes sense. What does it mean? It means first, do no harm. If you cannot help the patient also, do not harm the patient. And that goes against the very concept of oncologic allopathic care because all we want to do is harm. We do not want to not harm the patient. We want harm to be done. Right? What cancer? Kill it. What you are trying to protect it. So, but most of our oncology research next is based on pharmaceutical companies. Like the vaccine fiasco that we had about COVID, no? Similarly, everything in oncology right now is development, you would see, is by companies who are heavily invested into equipment, that is radiation, PET CT, robotic surgery, etc. Or pharmaceutical companies which have new MABs, MIBs, TABs, and a whole lot of other words which you cannot pronounce. Half my medical oncology colleagues who are above 50, no? They are really scared because they don't remember pembrolizumab. Okay, it is like so complicated. There is actually the nomenclature system for this, wherein which fragment, whether it is murine mouse antibody or humanized antibody, whether it is a chimeric antibody, all this has all this MAP, TAP, CAP, all this is there. But who remembers all this? And they keep changing. The best part about any of these MAP therapies that you see or immunotherapy, they would have been FDA approved, which is the golden, the holy grail for them. FDA approved means best. Why? Because they will get reimbursement. So their money will come back. They are not bothered about selling it in India because India, poor country, who will buy 98,000, 1 lakh worth of chemotherapy every month on month? This is a very poor market for them. We will wait, we will take off the patent, make generic and sell. That is all what we are good at and that is what we will do because we don't have R&D. We don't have major pharmaceutical companies investing in R&D. So ultimately what I'm trying to say is that every drug that is coming out is by R&D after millions and billions of dollars of research spent by a pharmaceutical company, not because they want to improve mankind, not because they want to cure cancer. It is because they can get this money back by selling the next blockbuster. It is like Shah Rukh Khan or Salman Khan coming up with the next blockbuster. They are not happy with what they have done. They want the next 100 crore or 500 crore or 600 crore. That is their new target. So this is the same way pharmaceutical companies are also operating. And that is why our other systems of medicine are really suffering because there is no money there. Nobody is willing to invest money there. Nobody is willing to do research there. Nobody is willing to publish. Nobody is willing to document. I always feel it atrocious that why don't we document? Why don't we just do 10 patient studies, 15 patient studies and prove and keep publishing and making noise by saying that this system works. Let us document it. I used to speak to AVP. They had an entire international research wing. They used to go to different countries and do research. And I'm saying Ayurvedic research being done in Czechoslovakia, Poland, Germany. Why not in India? We don't do our research here because they will pay. So our Ayurvedic physicians will go there and do research because there they'll get stipend. Here we don't even get that. Whose fault is it? Our fault. It is our own fault. It is us as a doctor community, we are very soft targets. Anyway, that's a totally different topic. Ayush, main problem I feel, no documentation. At least I am not aware of it. Maybe I am illiterate, maybe I don't read enough, that might be true. But it is your job also to educate me. As much as it is my job to educate myself. See, C P Mathew sir is a different breed. He went to Shivaganga, he wore dhoti, he slept with that man who didn't talk to him. That is a different matter. I might not be able to do the same thing. But can you help me out? Educate me. That's the simplest thing you can do because I'm very open to education. Thousands of years of knowledge you guys have between you all. Thousands of years. No trials, no sponsors, no marketing. But he studied, as I mentioned, he studied the powers, and this is before I listened to the video also, and I could realize from what he's written that so much capacity and it is used for so many patients without causing significant harm to them and with much benefits. And that's where I think I really feel, this dedicated series is a very worthwhile contribution to ongoing his legacy forward. But why we don't do IT? IT, integrated therapy, is, as I mentioned, lack of education. No active research going on in IT field right now, integrated therapy field. No documentation, no cross-training. Ayurvedic doctors have no idea about what homeopaths are talking about majority of the time. Homeopaths have no idea sometimes, but sir's lecture was a lot of allopathic terms. I was reasonably impressed, but I'm just saying, we have no training in any of that. That much I can say, very safely. Allopaths, if I say Ayurveda, they might chuck me out of the IMA hall next day. Because they are saying, you know what, that Ayurvedic doctor, he is prescribing paracetamol. What is your problem? Whether he is prescribing paracetamol or not, if it is working for the patient, fever is coming down, whether it is Ayurveda or paracetamol, what difference does it make to you? If I ask them, they will not talk to me. So this is another thing, we do not feel that we are brethren. Anyway, how I started doing it, I think I already mentioned. It is now the last slide. What are the thoughts for the future? It is more important to It is more important to know the patient than the disease. Is my firm belief. Document the obvious oncopalliative benefits is something that we should all try, especially people who are actively practicing oncology here. Try and lessen the suffering, especially when conventional treatment is too toxic or not beneficial. Definitely we should start introducing Ayush, and that is something I strongly started believing in. Stick to basics of treatment as much as possible. All the new fancy, real, beautiful molecules that they propagate have hardly improved survival, never improved survival. Never improved survival, and hardly by 5 or 10% they are even beneficial with a lot of side effects. And the last one is a saying which I learned from my Ayurvedic colleague. I practice with the Ayurvedic doctor, Dr. Ravi, which goes Vaidyo na Prabhu Aisha, which is, I don't know Sanskrit, but actually supposedly means that it's not the doctor who decides on your life. It is ultimately the universe and God which decides on your life. So we are just mere instruments in that pathway.